My name is Dr. Shalini Jaggi. I'm consultant diabetologist and director at Lifecare Diabetes Center, Kirti Nagar, New Delhi. I am also a member of the Executive Council of the Research Society of Study in Diabetes in India national body, as well as a governing council member of DIPSI, which is Diabetes in Pregnancy Study Group India. I'm also a fellow of the Royal Colleges of Physicians of London, Edinburgh, as a fellow of the American College of Endocrinology. Without taking much time, I would like to talk about the topic that I'm discussing today, which is gestational diabetes. This is a commonly encountered situation that we as physicians sometimes encounter. And what I'm going to do today in the next few minutes is talk about GDM from a diabetologist perspective on what exactly is GDM, why is it important to look for GDM and to manage GDM, and then we'll talk about how to manage this situation. So, we all know just like the burden of diabetes is increasing all over the world as well as in India, if you look at the burden of hyperglycemia in pregnancy in women in the reproductive age group, which means between 20 to 49 years, you see all across the globe there is an increase. But what is very, very disappointing is the Southeast Asia again leading in this with 26.6% prevalence of hyperglycemia in pregnancy. And out of this, what is more worrisome is the fact that 1 in 6 live births are still occurring to women with some form of hyperglycemia or the other. Out of percent of these are due to GDM or gestational diabetes mellitus. In fact, in our country, India alone, GDM complicates nearly 4 million pregnancies annually and hence the burden of the disease. And that is the reason why I'm here today to discuss GDM with you. About diabetes in pregnancy, we all know on the one side, we have women who already have pre-existing type 1 or 2 type 2 diabetes and plan to get pregnant. On the other hand, we have what is called gestational diabetes, which means either a fragment of women who probably had some amount of dysglycemia but were not aware of it, and diabetes is diagnosed for the first time once they come to you in pregnancy, or women with true gestational diabetes. Moving on to the definitions to distinguish between the two, conventionally, GDM was defined as any degree of glucose intolerance with onset of first recognition in pregnancy, regardless of the duration of pregnancy, regardless of the management, whether with insulin or tablets, or if the condition persisted after pregnancy. And pre-gestational diabetes or pre-GDM was any pregnant woman who was already known to have diabetes and comes to you in pregnancy. Currently, the ADA has defined women with diabetes diagnosed in the first trimester as typical women having pre-gestational diabetes, which means even if they are not aware, but the diagnosis happens in the first trimester, these are women with some amount of pre-existing dysglycemia and labeled as pre-GDM. While GDM or true GDM is diabetes that is diagnosed in the second or the third trimester of pregnancy, which is clearly not overt diabetes prior to pregnancy. DIPSI, on the other hand, recognizes GDM as a stage in the evolution of type 2 diabetes because primarily there is a state of chronic beta cell dysfunction which results in dysglycemia in pregnancy. And hence, it is very important to screen for it early and manage it as tightly as possible. Now, hyperglycemia during pregnancy, we all know, is associated with a high risk of maternal and perinatal morbidity and mortality. And the whole reason why we're talking about GDM is because of its impact on two lives. A diagnosis of GDM for the woman means a very high risk of future diabetes associated with metabolic problems besides the pregnancy. And a baby who is exposed to GDM or maternal hyperglycemia intrauterine, this baby, because of the gestational programming based on the fetal origin of adult disease, predisposes to all the different NCDs, metabolic problems as this baby grows up and he becomes obese, he may develop diabetes, he may develop hypertension. So it is two lives that are being impacted by GDM. Therefore, optimum diagnosis and management provides an opportunity for primary prevention of NCDs, including diabetes, in two generations, the mother as well as her baby. So what are the risk factors for GDM? Well, you should suspect GDM or look out for GDM in any woman who comes to you who is overweight or obese with a BMI more than 30, a lady who's given birth to a macrosomic baby or an overweight baby weighing more than 4.5 kilograms or above, a lady who's already had a history of GDM in her previous pregnancy or has a deranged oral glucose tolerance test before she becomes pregnant is at a very high risk of becoming GDM. Again, somebody who has a first degree relative with diabetes, a lady who's conceiving beyond the age of 25 years. When it comes to genes or ethnicity, South Asians like we women in India, Pakistan, Bangladesh, Black Caribbeans, Middle Easterns, all these ethnicities are at a high risk of developing GDM. Again, a lady who already has a history of MTPs, abortions, spontaneous abortions, or bad obs history, and a lady who already has PCOS, all these are high risk categories for development of GDM, and they should definitely be screened as early as possible for this condition. Now, what exactly happens is what I'm going to discuss now. Why does GDM happen? Well, in the words of Norman Frankel, fetus is a continuously feeding border in the body of an intermittently eating host, which is the mother. So, although the mother is eating from time to time, not 24 by 7, but the fetus needs its nutrition all the time. And therefore, the maternal metabolism in pregnancy undergoes certain changes physiologically to provide for an uninterrupted supply of nutrients to this fetus for its growth and its energy needs. Now, how does GDM occur? Let's look at the pathophysiology in very, very simple terms. So, in a non pregnant female, whatever little amount of insulin resistance is already present is compensated by healthy beta cells when there is no beta cell dysfunction by an optimum secretion of insulin, which compensates adequately for this insulin resistance, and therefore the blood glucose levels remain normal. What happens in a normal pregnancy, because of all these diabetogenic placental hormones that are produced in the body of the mother, especially in the middle and towards the end of the pregnancy, which means in the second and the third trimesters, there is a massive increase in insulin resistance which occurs. But if the beta cells are healthy, there is no beta cell dysfunction, there is a massive increase in insulin secretion, which parallels and takes care of this increasing insulin resistance to maintain normal blood glucose levels, and there is no GDM. But in ladies who have a family history, or all these ladies that I said, the ones who are at high risk, in their case, what happens is the insulin secretion is not able to compensate for the increasing insulin resistance that is happening because there is underlying beta cell dysfunction. So as a result, there is massive increase in insulin resistance, but the beta cells fail to compensate for this secretion, and therefore a certain amount of glucose intolerance develops in these ladies, resulting in an inability to the increased insulin secretion to overcome this insulin resistance, leading to dysglycemia or GDM in pregnancy. Now, why we're talking about this is because of the lifetime risk of type 2 diabetes going up in all these women who are diagnosed with gestational diabetes. Up to 50% of GDM women eventually do develop some amount of impaired glucose tolerance or progress to type 2 diabetes within 5 to 10 years of their delivery. And if you look at the 2021 ADA data, it clearly says women with GDM have a tenfold increased risk of developing type 2 diabetes compared to women who do not have GDM in their pregnancy. And this absolute risk for diabetes increases linearly through a woman's lifetime. So at 10 years, it goes up by 20%. By 20 years, it goes up by 30%, and so on and so forth, to going up to almost 60% down 15 years. What is also very important, and why we're talking of GDM, is because of the intergenerational risk of NCDs that leads to the progression of not only diabetes in the mother with GDM post delivery, but also the maternal obesity, the gestational weight gain, the in utero overnutrition. All of these lead to a gestational programming, which eventually results in epigenetic changes in the genes of the baby as well, which lead to an altered physiology in the offspring, leading to increased insulin resistance and some amount of beta cell dysfunction in this offspring, which grows up to become obese, has an increased risk of diabetes as well as an increased risk of developing cardiovascular disease. Hence, it is not only the mother but also her baby who has a very high risk of developing all these NCDs, and that is why we need to tackle this problem right in the bud. So, friends, GDM is a public health emergency which has grave implications for two generations, not only the mother, but also her children, because it is an established fact that there is a transgenerational transmission of this metabolic risk that occurs in all ladies with GDM. When we talk of the complications of hyperglycemia in pregnancy, if the hyperglycemia is in a pre-gestational woman or a woman who already has diabetes in the first trimester, of course, there is, like I said, an increased risk of congenital malformations, the cardiac neural tube defects, anencephaly, sacral agenesis, high incidence of stillbirths. But maternal complications include miscarriages in early pregnancy, high incidence of infections, preeclampsia, preterm labor, birth trauma, assisted delivery, and cesarean sections. Plus, the worsening of pre-existing microvascular complications in women who already have diabetes prior to pregnancy. But more important is women with pure gestational diabetes, that means hyperglycemia that is diagnosed in the second or third trimester. In them, of course, the congenital anomalies are not too common, but what is more disturbing is the fact that most of these ladies, if the hyperglycemia is not managed well, give birth to macrosomic or large for date babies. They are also predisposed to spontaneous abortions, intrauterine fetal death towards the term. The birth becomes difficult. The baby may have birth injuries, shoulder dystocia, infant respiratory distress syndrome, and so on and so forth. And like I said, these children born to obese mothers or mothers with GDM have a 7% increased risk of developing IGT by the time they are 7 to 10 years of age. Besides that, the mother also, like I said, has an increased risk of having polyhydramnios, prolonged labor, preterm delivery, C-section, abortions, uterine atony as well, besides the recurrence risk of GDM. So in the second pregnancy also, if she's developed GDM in the first pregnancy, the risk of getting GDM is 30 to 50%. And like I said, the lifetime risk keeps going up linearly. So GDM has effects both for the mother and the baby, not only in the current pregnancy, making labor difficult, making delivery difficult, leading to neonatal complications, but also beyond delivery in terms of the mother having a recurrent increased risk of GDM in the subsequent pregnancies, as well as an increased risk of developing diabetes, while the babies also tend to have an increased risk of becoming obese, developing diabetes, or having metabolic syndrome. Therefore, it is important that they are screened optimally for GDM as early as possible. Now, when it comes to screening for GDM, the ADA gives you a targeted high risk approach, which means that for women who do not have any previous history of diabetes and do not have any risk factors for GDM, for them, you can just do a screening in the high risk group, but only using the standard diagnostic criteria in the first prenatal visit. So a lady who has a high risk should be diagnosed at the first prenatal visit. But for a lady who does not have any history, does not have any risk of GDM, for them, testing is required only at 24 to 28 weeks of pregnancy, which means not all women need to be screened, except, of course, like I said, the high risk group. But like I said, we Asian Indians are a very high risk ethnic group for developing diabetes. Indian women have an 11-fold increased risk of developing glucose tolerance during pregnancy compared to the whites. And in India alone, GDM complicates nearly 4 million pregnancies annually. Therefore, all pregnant Indian women in India need to be screened for GDM. Therefore, the DIPSI guidelines very clearly advocate a universal approach for screening for GDM in all women who get pregnant. So the important question is when to screen. Well, like I said, the ADA says if it is not a high risk group, you can wait till 24 to 28 weeks. But in India, if screening is delayed till that time, there is a chance that you may miss out pre-existing dysglycemia in a very high risk ethnic population like us Indians. So it is very important that the first screening for GDM is done as early as possible, which means at the first antenatal visit in the first trimester itself when the lady comes to you. Moving on, how to screen? Well, different bodies, different organizations across the globe have their own different screening methods. So the ADA says one thing, the ACOG probably has another thing up their sleeve, the NICE UK follows something else, IADPSG advocates something else. So there's a lot of confusion here with DIPSI in India and FOXI having their own guidelines. If you look at the global ADA guidelines or the ADA recommendations, they give you a choice. You can follow any of these two choices. Either you can do a one-step approach, which means a 2-hour 75-gram oral glucose tolerance test, or you can follow a two-step approach, which means first on a non-fasting, you do a 50 grams glucose load test. And for ladies who are test positive here, for them, you call them fasting on a subsequent day and do a 100-gram OGTT for all screen positives, which means if you have done the one-step strategy, which means a 75-gram oral glucose tolerance test on a patient who is fasting, then if a fasting value exceeds 92, or a 1-hour value is more than 180, or a 2-hour value is more than 153, any one value positive, label her as GDM and proceed on the management. If you're following a two-step strategy, then for the first time when she comes to you in non-fasting state, you can give her a 50-gram glucose load test, check the glucose level at 1 hour. If that is more than 130 to 140, you call her fasting on a subsequent day, and then you do a fasting followed by a 100-gram oral glucose tolerance test and any two values positive, which means a fasting more than 95 or a 1 hour more than 180 or a 2 hour more than 155 or a 3 hour more than 140, you diagnose her as GDM and follow the management. Now this becomes pretty confusing. Now the existing diagnostic criteria, like I said, are country specific. What does the WHO say? Well, WHO says you can do a 75-gram oral glucose tolerance test in pregnancy using the same threshold of 2-hour post-glucose, which means more than 140, to diagnose GDM. What about India? Do we have some Indian guidelines? Well, yes, we do have the DIPSI guidelines, which are approved by the Ministry of Health, Government of India, the WHO, the IDF, as well as FIGO. DIPSI very clearly says that universal screening in pregnancy is very important in our country, and this should be as simple and as economical as possible so that we do not miss any lady from diagnosing GDM. So when a lady comes to you in the antenatal clinic at the first time, then after a preliminary clinical examination, irrespective of the time of last meal, which means she is fasting or non-fasting, all you need to do is give her 75-gram oral glucose dissolved in about 300 ml of water. Ask her to drink it over the next 5 to 10 minutes without regard to the time of the last meal. And then you do a 2-hour plasma glucose test. If this value is more than 140, diagnose her as GDM and follow all the standard protocols for management. The first testing should be done in the first trimester because almost 1/3 of these hyperglycemia positive women will be detected in this period or at the first antenatal contact. If the first test is negative, the second screening should be done again at around 24 to 28 weeks. Even if this test is negative, but the woman is a high-risk case for GDM or you are suspecting GDM, you may do a repeat test even at 32 to 34 weeks if required. So this is the document, this is the endorsement of the government, the adoption of the DIPSI guidelines, the National Guideline for Diagnosis and Management of GDM. This is available easily on the internet. You can download and go through this because the document very clearly says that already in India, the GDM rates are between 10 to 15%, which is much higher than the West. And the incidence of GDM is expected to go beyond 20%. So the time is not far when 1 in every 5 pregnant women is likely to develop GDM, and therefore it is important to look for GDM, screen it early, and manage. So this is the algorithm. A pregnant woman coming to you for the first antenatal visit, Test for GDM, just give her a 75 gram oral glucose to drink, do a 2-hour blood sugar value. If that is negative, that's fine. You may do a repeat testing at 24 to 28 weeks. And still, if that is negative and she is high risk, you may do it in the third trimester. But at any point in time, if you see a 2-hour blood glucose value exceeding 140, label her as GDM and manage as per the guidelines. Now, what are the glycemic targets in pregnancy? Well, ideally, once GDM is diagnosed, you need to maintain very tight glucose control, and ideally an HbA1c target in pregnancy is less than 6% if you are able to successfully achieve this without causing significant hypoglycemia. Of course, if the lady is going into hypoglycemia, which means blood glucose levels dipping less than 70, it may be relaxed to between 6.5 to even 7 insulin. So try to aim for a fasting plasma glucose less than equal to 95, a 1-hour post-meal value of less than 140, or a 2-hour post-meal value of less than 120 for adequate management. Just a quick note on using HbA1c in pregnancy. Of course, we know that in pregnancy, the red blood cell turnover is very high. So A1C is going to be slightly lower in normal pregnancy compared to non-pregnant women. Also, in pregnancy, one thing that we need to be very careful about is postprandial hyperglycemia, which is the hallmark of true GDM. And this we know drives macrosomia. Unfortunately, HbA1c being just an average is not able to pick up actual postprandial hyperglycemia. Therefore, the use of HbA1c in pregnancy is very limited. So if you're doing an A1c in early pregnancy, maybe it is useful in diagnosing pre-existing diabetes, by knowing the retrospective blood glucose control. So any lady who has dysglycemia prior to pregnancy or already is diabetic prior to pregnancy, a preconception A1C target has to be less than 6.5%. Ask her to first control her sugars, get an A1C of less than 6.5 before she plans pregnancy. But once the lady is pregnant, that means a true gestational diabetic. For them, it is important that throughout pregnancy, you target an A1C as close to possible as 6 so that all the complications can be avoided. Remember, using A1C is good for monitoring the control, but not for daily management, and therefore use it as a secondary measure of glucose control during pregnancy, only secondary to SMDG. Now, moving on to management. Well, the goal of GDM is not only to improve perinatal outcomes, but also to prevent the long-term maternal and fetal effects. So, an optimum management means optimizing glycemic control to a level where the fetus is not able to recognize hyperglycemia in the mother. Then only can you prevent the intergenerational transmission of obesity, of diabetes, of NCDs to the offspring. So as tight as possible, so much so that the glycemic levels are so normal that the baby is not able to even comprehend that the mother has GDM. That is your successful management of GDM. And like I said, the St. Vincent Declaration adopted by the WHO and the IDF clearly says an optimum management of GDM should be to achieve a pregnancy outcome in the diabetic woman that approximates that of a non-diabetic woman. So moving on to the management of hyperglycemia in pregnancy, of course, medical nutrition therapy and exercise are very, very important when it comes to GDM. But if ladies who fail on MNT and exercise, there is always pharmacotherapy, which means we'll talk about the orals as well as insulin. What is most important is providing psychological support. We keep talking about medications, we keep talking about diet, but somewhere down the line, it is very important that a diagnosis of diabetes in pregnancy can be very distressing for a woman as well as her family who's euphoric because of her pregnancy. So explain to her very clearly about the condition, reassure that if managed well, things can be very, very normal, educate her on diet, educate her on lifestyle, educate her on how to look after herself and the baby so that glycemic levels can be maintained as near normal as possible. When it comes to MNT and lifestyle, they form the cornerstone of GDM management, and effectively 70 to 85% of mild GDM cases can easily be managed by simple dietary changes and lifestyle modifications. So it is important that weight management, MNT, and physical activity are always stressed upon in all these ladies who develop GDM or are at a high risk of GDM if they come to you earlier on before planning pregnancy. Of course, because like I said, the glycemic targets in pregnancy are much more strict compared to non-pregnant targets. It is important that you tell the lady to eat consistently an adequate amount of carbohydrates to match insulin dose if insulin is being given, to avoid hyperglycemic excursions as well as hypoglycemias. And remember, pregnancy is not the time for weight loss. So severe calorie restriction or fasting should not be recommended to these women because this can result in ketonemia or ketonuria and may also impair the baby's growth, the physical and mental development of the offspring. So moving on, lifestyle management, physical activity. If there is no contraindication, if the lady is not prescribed bed rest by her gynecologist, ask her to walk as much as possible. Somewhere around 30 minutes per day is recommended, or maybe a 10-minute walk after every meal helps. It can improve metabolic control, especially if the diet is not working. Of course, any form of exercise is good, which does not involve any active exercise predisposing her to falls. Upper body exercises, simple walking, starting slow, gradually increasing the time and intensity can help. Moving on, as pregnancy progresses, glucose intolerance tends to worsen, especially 24, 28 weeks. Beyond that time, when there is a huge assault of all the placental hormones, the diabetogenic potential of these hormones predisposes to increase in glycemic levels, and the lady may ultimately need pharmacotherapy. If that is the case, remember, insulin is the preferred first-line medication for treating hyperglycemia in pregnancy. None of the currently available human insulin preparations are shown to cross placenta, so they are very, very safe in pregnancy. Of course, there have been individualized RCTs that have shown a limited efficacy of metformin as well as glyburide in maintaining glucose levels in GDM. These agents should not be used. They are not recommended as first-line treatment for GDM because they are known to cross placenta. Data on their long-term safety for offspring is of some concern. Data is coming out which is showing some problems in ladies who are given these drugs. So it is important that if it comes to pharmacotherapy, try to prefer insulin. Randomized double-blind controlled trials, even in women with PCOS who were on metformin, have clearly shown that there is no benefit of continuing metformin in preventing spontaneous abortions or GDM in these ladies. Therefore, there is no evidence base to actually continue metformin in such patients. But there is a small amount of women who may not be able to accept insulin because of probably cost issues, language barriers, comprehension, low IQ, less level of education, cultural influences. For these ladies, of course, what is primarily important is to maintain glycemia. And for them, after discussing the known risks and the want for long-term safety data in offspring, you may plan to use metformin. However, in ladies where there is a potential for growth restriction or acidosis, especially in a setting of placental insufficiency, do not use metformin, especially in women who have hypertension, preeclampsia, or there is IUGR already seen in the ultrasound scans. DIPSY very clearly says that if the woman is not willing for insulin or cannot take insulin for all these reasons that I told you, provided the gestational age or just pregnancy is beyond 12 weeks, you may start metformin from as low as 500 milligrams twice daily, go up to a maximum of maybe 2 grams per day or the maximum tolerated dose, and still, if it is not controlled, if glycemia is not on target, in spite of using metformin, in spite of MNT, there is no option. You need to advise insulin. So friends, let me reiterate. Insulin is the gold standard and has to be preferred in all cases needing pharmacotherapy. So what are the factors that predict need for insulin? If the lady is already presenting to you with a high fasting blood glucose, which is beyond 110, or post meals are beyond 140 in spite of MNT, if GDM is detected less than 20 weeks of pregnancy, the lady already has a past history of GDM, the age is advanced, high baseline A1C, if the lady is obese, BMI is too much, or if she's gained a lot of weight in pregnancy, if the pregnancy weight gain is beyond 20, or if the dysglycemia is not settling at less than 30 weeks, most of these ladies, or ladies with probably renal or hepatic dysfunction, ladies who are not tolerating metformin. So in all these cases, I think it's best to start insulin as early as possible to prevent all these complications. So like I said, insulin has to be the preferred agent for managing diabetes in pregnancy because, like I said, it does not cross placenta. Of course, insulin has to be individualized. You can use multiple daily insulin injections, or even a pump may be used for ladies where hyperglycemia is profound. There is no convincing evidence to say one insulin regime is better than the other. But like I said, in true gestational diabetes, usually what we see is an elevation in the postprandial or the post-breakfast glucose levels. In such cases, all you need is, beside MNT, a single dose of short or rapid-acting insulin before breakfast to circumvent that. Of course, a lady with pre-GDM or pre-existing diabetes, basal bolus regime is to be recommended. All human insulins, like I said, are safe in pregnancy. When it comes to the analog insulins, both Aspart and Lispro are approved for use in pregnancy. Of course, the glulisine data is still insufficient in pregnancy. Moving on to the basal analogs, insulin detamir has been approved for use in pregnancy. Degludec is not yet approved in pregnancy. As far as insulin glargine is concerned, there is emerging literature and it has been found safe in pregnancy. Of course, analog insulins, because they are faster, because they are predictable and cause less hypos, may be preferred, but if she cannot afford, even human insulins are good enough. Before we finish, when do you deliver? Well, GDM is not a sole indicator for cesarean delivery. So in a lady who has a normal pregnancy with normal estimated fetal weight, good metabolic control, good BPDs, normal amount of amniotic fluid, no major complications, plan a full-term normal delivery, which means around 38 to 39 weeks. An elective cesarean section, however, may be strongly considered if the baby is macrosomic. Try not to prolong gestation beyond 38 weeks because this again increases the risk of fetal macrosomia without reducing cesarean rates. So if there is no OBS emergency, you may wait till 38 to 39 weeks, max up to 40 weeks, but do not wait beyond that. So in a well-controlled lady with GDM with normal antenatal screening, allow the pregnancy to progress up to the EDD, but definitely not beyond 40 weeks. But if it is a poorly controlled patient, then of course an early delivery, the decision is taken by your OGCN as well, is indicated. How do you manage these ladies during labor or delivery is beyond the scope of today's talk. I refer you to this document, the RSSDI Clinical Practice Recommendations for Managing Inpatient in Hospital Hyperglycemia, which was published in the International Journal for Diabetes in Developing Countries in 2016. I happen to be one of the author group here. So you can refer to this document where we've talked about step-to-step management of diabetes, or how do you start an infusion and all those things during pregnancy, how to monitor. Moving on, once the lady has delivered, you will see a sharp decline in insulin requirement. So immediately you must stop insulin, but continue monitoring at least for the next 3 days. If it is a true gestational diabetes, you will see that immediately after delivery, within 24 hours, the glucose levels remit back to normal. So it is very uncommon in ladies with true GDM to actually have postpartum diabetes, but 15% of these GDM ladies do remain glucose intolerant and eventually develop type 2 diabetes in the postpartum period. And like I said, within 5 years of delivery, 10 to 50% of these ladies do develop diabetes if they are not careful about their diet post-delivery. Hence, at every visit, you must talk on the importance of weight control, diet, and exercise, both for the mother as well as for the baby. Explain the risk of GDM in subsequent pregnancies and screening for diabetes when planning a next pregnancy. This is where you need to very clearly highlight the importance of preconception counseling to all these ladies. Explain the risk of childhood obesity and diabetes to the baby born to a gestational diabetic mother also, because this is the time when the lady is very, very receptive to all that you are saying. So this is the time she will follow your advice. She will understand why you are talking about this. And of course, warn her that the danger is not yet gone. The glucose levels may have reverted to normal for the time being, but if she keeps piling up weight, if she does not follow good dietary advice, if she does not start exercising, obviously, eventually she will come back to you as a type 2 diabetic, and then the diabetes will not go away. Again, in between two pregnancies, even if the glucose levels are normal or in the impaired glucose range, you must talk about preconception counseling, which means before she plans the next pregnancy, she should definitely check her glucose level and plan a pregnancy only when the HbA1c is less than 6.5%. So, women with gestational diabetes should be tested for persistent diabetes or prediabetes at 4 to 12 weeks postpartum by subjecting them to a simple 75-gram oral glucose tolerance test using the non-pregnancy criteria. Remember, the criteria are different in pregnancy, but once the lady has delivered, you go back to the non-pregnancy criteria, which means a fasting more than equal to 126, a 2 hours post glucose more than equal to 200 to diagnose diabetes. Therefore, this should be immediate, this should be repeated, probably annually if possible. If the first 4 to 12 weeks postpartum 75-gram OGTT is normal, because like I showed you, the risk keeps increasing as the years pass. And especially if she's planning a second pregnancy, you must warn her to be very, very vigilant when it comes to her diet, when it comes to gaining weight, and her A1C. So, friends, to summarize, hyperglycemia in pregnancy as well as gestational diabetes are both associated with an increased risk of both maternal as well as fetal complications. All guidelines recommend an early screening and diagnosis of GDM, especially the DIPSI guidelines when it comes to women in India, followed by an optimum glycemic control to prevent the risk of maternal-fetal complications and to improve outcomes in these ladies. Medical nutrition therapy and lifestyle modification form the cornerstone of GDM management. Of course, if she needs pharmacotherapy, if she is failing on MNT and lifestyle modification, insulin is the preferred agent for managing any form of diabetes in pregnancy. Of course, insulin therapy has to be individualized based on the level of dysglycemia that the lady has. If it is isolated postprandial hyperglycemia, a single shot of rapid acting or a short acting insulin may suffice. If there is hyperglycemia, especially fasting hyperglycemia, you may need to give a basal insulin such as detamir for this lady. Oral agents like metformin may be an alternative where insulin is not acceptable or not possible. After a detailed discussion of the known risks and the need for more long-term safety data in the offspring on the safety of these oral agents, women with GDM should be tested for persistent diabetes or prediabetes at 4 to 12 weeks postpartum and every year thereafter, lifelong. Tell them to make it a habit to keep checking their glucose levels if they've had one history of gestational diabetes, so that they can actually preempt onset of dysglycemia or prevent diabetes if they are able to lose an optimum amount of weight and maintain good diet and exercise regularly. So, friends, pregnancy offers a window of opportunity to provide maternal care services to reduce the traditional maternal and perinatal morbidity and mortality indicators, as well as address the intergenerational prevention of NCDs such as diabetes, hypertension, cardiovascular disease, and strokes. It is very important that early diagnosis and optimum management of GDM is done. It is the need of the hour in our population where we are at such a high risk of developing diabetes. And to achieve eventually a diabetes-free generation, in the words of Professor Seshaya, who heads DIPSI, who's the father of GDM in India, We need to focus on the fetus for the future, because these babies who are exposed to GDM in pregnancy eventually do develop diabetes. So both the mother as well as the baby are at risk for all these NCDs, and hence an early detection of GDM and optimum management of GDM can not only help the mother have a smooth pregnancy and a normal delivery, but also prevent this baby from developing metabolic syndrome later on at birth. Well, we have a large number of questions. I'll try to pick up as many as possible and address them. There's this question from Dr. Gulab Jada from Maharashtra, who says, what are the retinal changes in GDM? Well, doctor, if you're talking of true gestational diabetes, which means diabetes in the second or third trimester, there will be no retinopathy in these cases, because this is very transient dysglycemia that has occurred only as a result of diabetogenic hormones during pregnancy. So this woman is not at an increased risk of retinopathy. But if it is a pre-gestational diabetic, that means a woman who already has type 1 diabetes or type 2 diabetes prior to becoming pregnant, this woman, before she gets pregnant, like I said, preconception counseling is very important. So this woman, before she becomes pregnant, should definitely undergo a retinopathy assessment to rule out any background retinopathy, because literature has shown that a woman who already has background retinopathy during pregnancy, because of the pregnancy hormones and because of the stringent glycemic control, sometimes there is a worsening of retinopathy that can occur in pregnancy. So for all ladies who are already diabetic prior to pregnancy, there is an increased risk of retinopathy progression, and therefore they should be screened and treated for retinopathy prior to they becoming pregnant. But for true GDM, retinopathy is not really a problem. Moving on, I have this question. Beyond how much blood sugar, this is a question from Andhra Pradesh, Dr. Dash. Beyond how much blood sugar we need to start insulin at first detection of GDM, and in patients on insulin, how many days interval should the testing and monitoring of glucose should be done? An excellent question, doctor. So if it is a true gestational diabetes, that means, you've picked up gestational diabetes at 24 weeks, 28 weeks, or towards the late pregnancy, then if the degree of dysglycemia is mild, that means the fasting is somewhere around 100 or the post meals are around 140 to 150, you can give her about 2 weeks of strict diet control, exercise, and ask her to monitor her glucose levels. Monitoring, you may ask her to check a fasting as well as a 2-hour post meal, which means either a post breakfast, a post lunch, and a post dinner. If the fasting with diet control with exercise comes to less than 95, or the post meal 2 hour is less than 120, then she can continue with MNT and lifestyle. But in spite of diet, if the glucose levels are beyond target, or if at first presentation itself the fasting is beyond 110, or post meals are beyond 120, 140, 2-hour post meal is exceeding 140, then definitely it is time that you start insulin as early as possible, which means hyperglycemia is pretty severe. Okay, so there is another question on metformin and sitagliptin combination in pregnancy. No, I'm sorry, doctor. Sitagliptin, or for that matter, none of the other oral agents is recommended in pregnancy. We do have data on use of metformin in pregnancy, but it has been shown that women who were given metformin in early pregnancy, their children eventually after birth tend to be obese. There is data from lot of studies which have shown that metformin in early pregnancy can cause problems to the offspring later on in life. So if at all metformin has to be given, it should be initiated only after 12 weeks. And if it is failing and beyond diet control and metformin glucose levels are not controlled, then definitely there is a case for insulin for these ladies. Sitagliptin, for that matter, all the DPP-4 inhibitors, none of them is safe in pregnancy and they should not be given or continued. So if a lady who is already diabetic is planning to conceive, please discontinue all these different oral agents. Preconception itself, It's always better to put them on insulin when they are planning pregnancy, so that when the conception occurs, that early pregnancy, the early 6 to 8 weeks of pregnancy is very, very crucial for organ development for the baby. So if the lady is already on insulin, all you need to do is monitor the glucose levels and increase insulin doses so that the organogenesis happens without any complications. So it is important that preconception counseling is done for all these ladies with prior diabetes. Okay, so there is again this question on from West Bengal on what oral anti-glycemic drugs are safe in pregnancy. I think I've talked about metformin, which can be given after 12 weeks, but then, like I said, if possible, insulin is the safest. Is there any safety? There is this question from Dr. Amit Bhaskar from Bihar. Is there any safety literature of newer insulin analogs like Aspart, Lispro, Novomix, Novorapid, Humalog, and Glargine? Well, doctor, I did mention this. The analogs Lispro and Aspart both have been shown to be safe in pregnancy. Even the ultra-fast acting Fiasp insulin is safe in pregnancy. There's a lot of data to support, and they are safe. When it comes to the basal insulins, Detamir is approved in pregnancy and very safe. Earlier, Glargine was not indicated in pregnancy because of the increased risk of probable, the IGF action. But now it is very clearly shown that women who are on Glargine prior to pregnancy, if they are continued on Glargine through pregnancy, there are no adverse outcomes. So you can continue with Glargine in pregnancy as well. Of course, with the newer insulin, Degludec or Tresiba, there is no data as yet on in pregnancy. So better not to use insulins that are not yet declared safe in pregnancy. Maybe at a future time, if we have safety data, they may be used. I will not take questions. There is this question on Afreeza, which is inhaled insulin in pregnancy. Well, it is not present in our country, so we do not have any experience with inhaled insulin. Of course, the studies show that inhaled insulin, Afreeza, leads to a very rapid control of postprandial glucose. So probably in the future, once we start using it, we may be using it, but as of now, not seen in India. There is this question on which insulin regime is to be preferred in a pregnant woman with diabetes. Well, like I said, if the lady already has diabetes, there are full chances that both her fasting as well as post-meal glucose levels are going to go up. So for these ladies, it has been very clearly shown that a basal bolus regime has to be given to all ladies with pre-existing diabetes. So if the fasting glucose is more than 95, 1 hour value is more than 140, or the 2 hour post meal value is more than 120, you need to take care of that by giving them a pre-meal bolus insulin in the form of a rapid acting or a short acting. So if you are using analogs, you can give her Lispro or Aspart shot before breakfast, before lunch, and before dinner. If you are using conventional insulins, you can give her human insulin R or Act Rapid before breakfast, before lunch, or before dinner. To take care of the fasting plasma glucose, you can put her on NPH if you are using a conventional insulin. But of course, NPH causes a little more hypoglycemia. Therefore, it is safe to put her on something like Detamir insulin, which very effectively is able to manage the fasting plasma glucose. So based on the fasting levels, you can increase the Detamir insulin dose. Based on the post-meal levels, you can increase the rapid acting shots. Of course, if it is a woman with gestational diabetes, usually the fasting remains normal on target, so you need not address that. Essentially, what you see is an increase after meals. So if after meals, in spite of MNT, if the 2 hour value is going beyond 120, you may plan to add a shot of rapid acting insulin in the form of Aspart or Lispro, or a short acting insulin in the form of human insulin R or Act Rapid. Of course, if the fasting goes up, a basal insulin may be needed. So basal, there are certain people who try to use premix insulin twice a day, which means either a mixed start twice a day or probably the premix analogs twice a day before breakfast and before dinner. Well, there is no contraindication to using them if you are able to get glucose levels on target. But in my own clinical experience, a premix insulin is not able to address the post meal jumps, which means especially the post lunch values may still go up, because even if you are using a premix 50-50 combination in the morning, it may address the post breakfast value, but the post lunch still tends to go up. So in those cases, maybe a bolus of a rapid acting insulin may be given. Again, a premix in the night may or may not address the post dinner jump. So if your patient is able to maintain the fasting and all the three post meals on goal with the premix insulin, please go ahead, you may continue it. But if you see that the fastings are still okay, but the post meals are not under control, remember, like I said, the post meal glucose levels are essentially the ones that lead to macrosomia. So it is very important that in pregnancy, the postprandial hyperglycemia is managed to target, which means a 1 hour target of less than 140 or a 2 hour target less than 120. If the glucose levels are beyond this target, the baby can become macrosomic. So it is important that you initiate rapid acting or short acting insulin so that the postprandial sugars can be controlled very well. Moving on. What exercise is recommended for pregnant woman? Like I said, simple walk. Just ask her to walk as much as possible. If the gynecologist is not putting your patient on bed rest, if there is no contraindication, a simple walk of half an hour to 40 minutes is good enough. If your lady, if she wants to swim, she can do swimming. Of course, high intensity exercises such as skipping cannot be done. Otherwise, we've had ladies who are marathon runners, so all through their pregnancy, if they are comfortable running around, which is not causing too much of a problem, they can continue, but the obstetrician has to give a go ahead to that form of exercise. So just to make it very clear, a simple walk of half an hour to 45 minutes every day, or even simple walk after every meal, a 10 minutes, 15 minutes walk, whatever she can do in her comfort zone is going to help her. So if the mother has GDM, does the child become prone to developing diabetes? Yes, of course. This is what is the fetal origin of adult disease hypothesis. Barker hypothesis. Very clearly this says that if intrauterine, the baby is exposed to hyperglycemia, uncontrolled blood sugars in the mother, transplacentally, the blood is common between the mother and the baby. So if there is hyperglycemia in the mother, the same placental, the same glucose is going to be sensed by the fetal pancreas. So this fetal pancreas will again detect this hyperglycemia in the maternal blood, and they will also get stimulated, leading to a certain amount of beta cell dysfunction in the fetus. So as a result, these children will also have a propensity to develop some amount of beta cell dysfunction, which is intrauterine or gestational programming for future risk of metabolic diseases. So these babies will have an increased risk of developing insulin resistance after birth, especially if they are overfed, if they are becoming obese, if they are putting on a lot of weight, if they are sedentary. So it is important that you tell the mother not only to exercise and lose weight herself, but also to ensure that her child who has already been exposed to GDM in pregnancy is brought up eating a healthy diet, doing exercise, indulging in outdoor sports, running, cycling, badminton, whatever. See to it that these babies do not become obese. Because the moment these babies become obese, the risk of developing diabetes early on increases manifold in these babies. Moving on, again, there was this question on glargine safety and recommendation. Like I said, glargine is considered safe in pregnancy and can be used as a basal insulin if the fasting hyperglycemia is to be controlled, if the fasting plasma glucose levels are high. Moving on, there's a question from Dr. Mehta from Maharashtra on hyperglycemia management during lactation. Again, like I said, the oral drugs, just as we know they cross placenta during pregnancy, similarly, the oral drugs are secreted in breast milk also. So as long as the lady is lactating, it is best to continue insulin if possible. If she is on metformin, although it is secreted in breast milk, but has still been found safe in the baby. But if the lady is already a diabetic and dysglycemia or diabetes is continuing beyond pregnancy, of course, you may not have to have a basal bolus regime, but at least a premix twice insulin to keep the glucose levels on target is of course required. So insulin is safe not only in pregnancy, but also during breastfeeding, because again, like I said, neither does it cross placenta, nor is it excreted in breast milk. So it is ultimately very, very safe. So there is this question from Dr. Jitendra Kumar Shah from Gujarat on how pregnancy affects HbA1c. I told you, doctor, during pregnancy, there is a very rapid turnover of red blood cells. Now, HbA1c is dependent on the RBC lifespan. And we know that the lifespan of an RBC is 120 days. So HbA1c actually tells you the glycemic level retrospectively in the last 3 months. So in pregnancy, when there is a rapid turnover of blood cells, red blood cells, obviously the HbA1c needs to be done on a monthly basis, because the red blood cells are dying out and new cells are coming much faster than in a non-pregnant adult. Therefore, HbA1c has limited use in pregnancy. Again, the whole idea of doing an HbA1c in early pregnancy is just to rule out pre-existing diabetes. But beyond that, as a measure of control, HbA1c should ideally is not really recommended, because what is more important is self-monitoring of blood glucose, because each postprandial peak or even a fasting hyperglycemia can lead to polyhydramnios, can lead to macrosomia, can lead to all the complications that I have been talking of. So in pregnancy, it is important to do SMBG. Maybe if you want to do an HbA1c as a measure of retrospective glycemic control for the last 1 month, you may do an HbA1c on a monthly basis. And even a serum fructosamine assay, which tells you about the retrospective glucose levels in the last 2 to 3 weeks, may be done in pregnancy. But I think HbA1c or fructosamine, rather than that, it is important that you tell her to buy a glucometer and do SMBG at home. Okay, so there is this question from Dr. Anjum Khalid from Kerala. If for PCOS, the mother is on metformin, should it be stopped in pregnancy? Yes, doctor. There are a lot of studies that have shown that if the lady is on metformin in early pregnancy, then these children who are exposed to metformin in early pregnancy may develop obesity, may develop, are born little underweight or at times overweight. And continuing metformin has not shown much benefit. The whole idea of giving metformin is to prevent development of GDM in PCOS pregnancy. So it has been shown that metformin is not really preventing development of GDM. Neither is it reducing stillbirths. And eventually, these ladies eventually fail to achieve glycemic targets on metformin, and you need to add insulin. So why not add insulin right in the beginning? But all said and done, if there is a mild degree of dysglycemia, metformin can be initiated beyond 12 weeks of pregnancy. So, what other oral molecules are advised in lactation? Dr. Rangarajan from Tamil Nadu wants to know, well, doctor, I said metformin is the only oral agent that may be used in lactation. Otherwise, it is insulin, and only insulin. So I think it's time to wind up. I think we've addressed most of the questions that I could see. And if you have any more questions, maybe you can just put them in the posts and we'll try to address them post the session. I think with that, maybe we can wind up.